All right. Hello and welcome everyone to our 11th MACRA info session under this iteration of the Measures Management System contract. I'm Brenna Rabel and I oversee education and outreach on this project. Today's session is unique from others we've done this year. So today you're going to be hearing from CMS staff about the Merit-Based Incentive Payment System, which you're probably more familiar with as MIPS. And we also have members of the MIPS Practice Improvement and Measures Management Support Team on the line to support Q&A at the end of the call. So as you know by now, these monthly info sessions are part of an ongoing effort to engage measure developers and other stakeholders in quality measurement topics, an effort that also includes a series of newsletters and bulletins, along with special announcement emails, public webinars, and routine updates to the Measures Management System website. These sessions occur about once per month and focus on a wide range of topics related to quality measure development. Before we jump into today's presentation, I do just want to cover a few housekeeping items. First, today's session is being recorded. Second, all participants will be muted during the call. We are going to have an opportunity for Q&A at the end of the discussion, during which the lines will be unmuted for questions. You probably also noted at the beginning of the session that we will use a hand raise feature for questions as well. And as always, you can field your questions in the Q&A box or in the chat feature if you'd prefer that to speaking up. And finally, the presentation slides from today's session will be posted to the MMS website at a later date. And so with that, I'm going to pass the presentation over to Susan Arday from CMS to kick off the presentation. Susan?
Hi, this is Susan Arday, and thank you for joining us today on this presentation that Sophia Sugamar, myself, and Dan Reiner will be giving, along with the PIMS team on the Quality Payment Program, the Merit-Based Incentive Payment System Annual Call for Quality Measures. So today's webinar topics, we're going to introduce the Merit-Based Incentive Payment System, MIPS. We're going to do an overview of the existing MIPS quality measures. Then we're going to address how new quality measures are implemented in MIPS. Next, we'll talk about the QCDR measures compared to MIPS quality measures. And finally, then we'll cover public reporting on Physician Compare. So now let's get into this introduction on the Merit-Based Incentive Payment System, MIPS. The MIPS, or Merit-Based Incentive Payment System, is part of the Quality Payment Program, and it's due to the Medicare Access and CHIP Reauthorization Act of 2015, or MACRA, as many of you are familiar with hearing. And under MACRA, the sustainable growth rate, the SGR formula, which would have resulted in a significant cut to payment rates for clinicians participating in Medicare, was ended. MACRA requires CMS by law to implement an incentive program referred to as the Quality Payment Program, or QPP, which provides two participation tracks for clinicians. MIPS is one of those tracks, and the other track is the Advanced Alternative Payment Models, or APMs. Many of you, if you're a MIPS-eligible clinician, you will be subject to a performance-based payment adjustment through MIPS. If you decide to take part in an Advanced Alternative Payment Model, or APM, you can earn a Medicare incentive payment for sufficiently participating in an innovative payment model. The Merit-Based Incentive Payment System phases out Medicare legacy programs that I imagine many of you are quite familiar with, and it combines those legacy programs into a single improved program. Well, what are those programs, legacy programs that went into MIPS? Well, one is the Physician Quality Reporting System, or PQRS. Another is the Value-Based Payment Modifier, or VM. And finally, the Medicare Electronic Health Record, or EHR, Incentive Payment Program for eligible professionals. So the example shown on the slide is of the legacy program phase-out of PQRS. So the last performance period for PQRS was the year of 2016, and the last PQRS payment ended in calendar year 2018. So how does MIPS relate to the legacy programs? Well, this visualization on the screen shows how the legacy programs streamline into the MIPS performance categories. So if a clinician or group was participating in PQRS, that's similar under MIPS to the quality performance category. If you are participating in VM, which would also include elements of the PQRS quality data, that now maps to the MIPS performance category of cost. And if you participated in the past in the EHR legacy program, that was streamlined into the MIPS performance category called Promoting Interoperability, or PI. So what is the MIPS, or Merit-Based Incentive Payment System? Well, it moves Medicare Part B clinicians to a performance payment system where your score is based off percentages in performance categories. So in the current performance year, 2019, which you see on the slide here, quality counts for 45% of the MIPS score. Cost counts for 15% of the MIPS score. Improvement activities, or what you'll hear us call IAs, it accounts for 15% of your MIPS score. And promoting interoperability, or PI, counts for 25% of your MIPS score. And you sum that all up, 45, 15, 15, and 25, and that'll get you 100% of your MIPS final score. This MIPS provides clinicians with flexibility to choose the activities and measures that are most meaningful to the practices. The MIPS reporting standards align with advanced APMs whenever possible. And you'll note in the slide here that the weights assigned to each category are based, as I mentioned, on a 1 to 100 point scale. The weights can be adjusted in certain circumstances. And as I mentioned previously, these weights are effective for performance year 2019 of MIPS. We have a large number of MIPS-eligible clinicians that can participate in performance year 2019. For 2019, the MIPS-eligible clinicians include physicians, physician's assistants, nurse practitioners, clinical nurse specialists, certified registered nurse anesthetists, clinical psychologists, physical therapists, occupational therapists, qualified speech language pathologists, qualified audiologists, and registered dietitians or nutrition professionals. And also you can have groups of such clinicians. And you'll note on the slide that there's an asterisk after several of these MIPS-eligible clinician groups, like clinical psychologists, physical therapists, occupational therapists, qualified audiologists, qualified speech language pathologists, and registered dietitians or nutrition professionals. And that's because those are new MIPS clinician types for performance year 2019. Questions that often come up are about what is the low volume threshold determination. And the MIPS-eligible clinicians who meet or exceed at least one, but not all, of the low volume threshold criteria may choose to participate in MIPS. And on the slide, you'll see there's a number of MIPS opt-in scenarios based on dollar amounts in the hundreds of thousands, beneficiaries, professional in terms of numbers of beneficiaries seen in a given performance period, professional services in terms of the number rendered in a performance year, and whether or not the entity would be eligible for opting in. So in addition to being one of the eligible clinician types in the previous slide we just talked about, clinicians that bill more than $90,000 a year in Medicare Part B allowed charges and provide covered professional services to more than 200 Part B enrolled Medicare beneficiaries and provide more than 200 covered professional services under the physician fee schedule, or you'll hear us call it PFS, are required to participate in MIPS. And as this table shows, or chart, if a provider meets one or more of the criteria, they are eligible to opt in and participate in MIPS. If clinicians do not exceed all three criterion, they are excluded from MIPS. So what would that mean? You bill more than $90,000 a year and allow charges for covered professional services under the Medicare physician fee schedule, and you furnish covered professional services to more than 200 Medicare beneficiaries, and you provide more than 200 covered professional services under the Physician Fee Schedule Final Rule, PFS. I'd like to segue us into an overview of the existing MIPS quality measures. There are 257 quality measures in MIPS for performance year 2019. 19 of those measures are owned and maintained by CMS, so that means CMS is the owner-steward of those measures. 238 of those measures, or as you'll note, the vast majority, are owned and maintained by other stakeholders who are the stewards and developers of those measures. If we break this out by measure type, for the 2019 MIPS performance year, the majority of the measures, quality measures in the program, are process measures. So, for example, 170 of the measures are process or process-to-outcome measures. So a good example of that would be the measure documentation of current medications in the medical record. 50 of the 2019 MIPS quality measures are outcome measures. Example of that is the optimal asthma control measure. 18 of the 2019 MIPS quality measures are patient-reported outcomes. An example of that kind of measure would be quality of life assessment for patients with primary headache disorders. 7 of the MIPS 2019 quality measures are intermediate outcomes. A good example of that would be diabetes, hemoglobin A1C poor control, where the A1C for the patient is greater than 9%. 7 of the MIPS 2019 quality measures are efficiency measures. Example of that would be cardiac stress imaging not meeting appropriate use criteria. So, for example, preoperative evaluation in low-risk surgery patients. 4 of the MIPS 2019 quality measures are structural measures. An example of that is the melanoma continuity of care recall system measure. And finally, one of the 2019 MIPS quality measures is a patient experience measure, and that's CAHPS, C-A-H-P-S. These 174 MIPS quality measures that fall, there are 174 MIPS quality measures that fall into a high priority area. And how do those high priority areas, what domains do they fall into for the measures? Well, they fall into person and caregiver-centered experience and outcomes. They fall into communication and care coordination. So an example of a high priority area measure under communication and care coordination would be pain assessment and follow-up. There's also a high priority area of efficiency and cost reduction. And an example of that would be the measure prostate cancer, avoidance of overuse of bone scan for staging low-risk prostate cancer patients. Another high priority area is patient safety. A good example of that kind of measure is the prevention of central venous catheter, CVC-related bloodstream infections. We also have designated as high priority appropriate use. So an example of that would be appropriate treatment for children with upper respiratory infections, URIs. I'd like to also note that outcome and opioid measures are high priority for MIPS quality. The chart that you now see in the diagram, many of you I'm sure have seen this. This is for the existing MIPS quality measures. This is the MIPS measures by meaningful measure area, or MMA. And you'll see the breakdown here across the various categories. The categories where we in MIPS have the most quality measures are management of chronic conditions, where we have 47 MIPS quality measures, appropriate use of health care, where we have 45 quality measures, and preventive care, where we have 36 MIPS quality measures. I'd like to note that the MIPS measures by meaningful measure area include 3 in the admissions and readmissions to hospital area. Let's see, 4 in the care is personalized and aligned with patients' goals. 4 under the end-of-life care according to preference. 25 under functional outcomes. 7 under healthcare-associated infections. 6 under medication management, 2 under patient-focused episode of care, 3 under patient experience of care, 23 under preventable healthcare harm, 10 under prevention and treatment of opioid and substance use disorders, 19 MIPS quality measures fall under prevention, treatment, and management of mental health, and 2 fall in risk-adjusted mortality. Finally, 21 of them fall into the transfer of health information and interoperability category. What I would recommend to study up more on this would, if you would visit the CMS MMA website, which is on cms.gov, for more information regarding the Meaningful Measures Area Initiative, the MMA. Next. Now we get to the good stuff, the 2019 Call for Quality Measures. Question we get all the time: how do quality measures enter MIPS? Well, there's an annual call for quality measures. The MIPS quality measures go through the same pre-rulemaking process that my understanding that Kim Rawlings walked folks through last month in the seminar series. The call for quality measures is the start annually of a process, and it allows organizations such as professional associations and medical societies to identify and submit measures for consideration for the quality performance category in MIPS. The current 2019 call for measures opened on March 1st of 2019 and closed on June 3rd of 2019. I'd like to note that measures have also entered the MIPS program through alignment with the Core Measures Collaborative, which is a very important collaborative initiative. The quality measure criteria. Well, when measures are submitted to CMS through the annual call for measures process, CMS takes a look at certain criteria. And the measures that are submitted for the quality measures should align with the criteria and goals of the MIPS program, and those can be found in the 2019 Call for Quality Measures fact sheet on the QPP resource library. We give the URL on the slide, but for those of you that might not be looking at the slide, you'd want to go to qpp.cms.gov, look at About, and then go to Resource-Library. You also would want to take a look at aligning with the criteria and goals of the program as stated in the publicly posted CMS Needs and Priorities on our CMS Needs and Priorities pre-rulemaking website, which is found on the cms.gov website under Medicare, Quality Initiatives, Patient Assessment Instruments, Quality Measures, and Pre-Rulemaking. It's really important that the quality measures that are submitted under the call for measures should not be duplicative of a current quality measure within the MIPS program. The measure should be clinically relevant and address a gap in care. We require that the measure be fully developed at the time of submission, which in this current cycle would have been no later than June 3rd of 2019. The measure submission must include reliability and validity testing information. We also require that you complete and include a completed peer review article form template, which we provide publicly on our website. This is kind of ties into the whole measure life cycle, and the measure life cycle includes publication of the measure on the MUC list, the Measures Under Consideration list. Then that MUC list is reviewed by the National Quality Forum's Measures Application Partnership, or you're going to say MAP. Then if the measure is approved for inclusion in the upcoming cycle of the proposed rule, in this case the physician fee schedule, it would be put in there, and then it would be subject to the open public comment period under that proposed rule. If it makes it through that cut and makes it into the final rule, it'll be published in there, and it'll be added to the final rule for inclusion in the program. So, for example, to give you an idea, if a quality measure is submitted for MIPS to the call for measures in 2019, to this current cycle, and then along the way it gets approved through this process I just kind of described, it may be included in the quality payment program's final rule, which is the physician fee schedule. for the 2021 performance year. I'd like to address a few more of the MIPS quality measure criteria. As I stated earlier in the presentation, CMS gives preference to high priority measures. We also give preference to measures focusing on topics that are not currently represented in the program and to measures addressing specialties that are not fully represented. So each quality measure submission must be accompanied by a completed peer-reviewed journal article form, which I just discussed, and the measure steward submitter attaches that completed template to the measure submission. That template, we get this question often, the peer-reviewed journal article form template is specific to the MIPS program only, and that template allows the measure steward to provide CMS the details about the measures they are submitting. And how do you submit those? They would be submitted while the call for measures is open out in the ONC project tracking system in their one of their projects, which is under JIRA, J-I-R-A. So why do we do this peer-reviewed journal article form? Well, that's done because CMS is required to submit new quality measures and the methods for developing those measures for publication in an applicable, specialty appropriate peer-reviewed journal. And that's done in order to add new measures into MIPS. So it's an important step. And as I mentioned, measures are submitted through the ONC Project Tracking Systems JIRA tool, where there is, I believe, a link in the slides when you get your hard copy of your slides through email. So the call for measures and MUD list, M-U-D. As Kim Rawlings talked about last month, measures that are submitted to the annual call for quality measures at CMS, but we find they're not fully developed and ready for implementation, we might add them to the MUD, the Measures Under Development list. And that lists measures that are in the process of being developed for eventual consideration for a CMS program, MIPS or otherwise. These measures are populated using measure developer submissions to the MIDS resource library and measures submitted for consideration in the pre-rulemaking process, but where those measures have not been accepted into a program at this time. So current MIPS quality measures are resubmitted through the call for measures, and that does happen if the measure owner steward suggests something along the lines of the following. For example, expanding the measure into other CMS programs that follow the pre-rulemaking process, expanding a measure to another collection type like an electronic clinical quality measure, ECQM, and significant changes to the measure. Another reason you might have to resubmit to the call for measures is if your measure is sensitive or has controversial changes in clinical guidelines, technologies, intent of a measure, which is somewhat, I would say, at CMS's discretion, or if your measure has changes to the level of its analysis. In other words, initially your measure was designed, tested, and vetted at the level of the facility for analysis and reporting, but now you've worked on it and adapted it, and you've also got it where it can be used at the level of analysis for clinicians. That would need to come back in through the call for measures. So here's a high-level MIPS quality measure life cycle on your screen. The measures submitted to the 2019 MUC list, as I mentioned earlier, may be available for reporting during the 2021 MIPS performance period. After measures are submitted through the call for measures, those that are approved go on to the MUC list, and those measures are then reviewed by the NQF MAP, the Measures Application Partnership. CMS does require the measure stewards to attend the NQF MAP meeting, which is usually occurs in December of each year, and it's downtown in D.C. at NQF's headquarters. And that is that you can attend by phone or in person, and that's so you can address questions that may come up for measures that you're the steward of and were developed outside of CMS. CMS, we address the questions that come up at the MAP for our measures, along with our contractors who support us in that. CMS also takes the MAP's recommendations into consideration in terms of things that might have to happen in the measure to make it more usable, whether or not the measure might be included in rulemaking or not. So after this process with the MAP, the approved measures are proposed by CMS in the proposed rule, and then are subject to the open public comment period. Then those measures are added to the final rule for inclusion in the program. So the total timeline for adding new quality measures into MIPS spans 2 years. So measures that were submitted to the CMS call for measures in 2019 and then are approved through the process will be available for reporting in the 2021 MIPS performance year, unless by chance in the rule we say otherwise, that we want to delay for a year or something. And occasionally that happens, but the chart on your screen shows this very nicely, how this kind of, the steps involved. And this slide right here gives you a little more detail regarding the milestones that occur from beginning to end, in this case in the 2019 to 2020 measures under consideration list publishing, which runs pretty much here. We've got the alpha to omega. March 1st of 2019, the JIRA opened. The Project Tracking System JIRA opened for new measures to be considered, and it goes all the way through to February 1st to March 15th of 2020 next year. I'd like to point out to you that the National Quality Forum, NQF, facilitates 2 public comment periods. The first public commenting period takes place after the publishing of the MUC, the Measures Under Consideration list, until the annual December MAP work group meetings occur. So in this cycle, that'll be in December of 2019. The second public commenting period that NQF facilitates takes place after the last December MAP work group committee meeting, which will be, again, December of 2019, and before the MAP coordinating committee meets in January. So for us, this will be January of 2020 in this cycle. And that's delineated here on your slide. You can, if you want more detail on this, you can also go to www.qualityforum.org/MAP, M-A-P. Now I have the pleasure to hand this over to Sophia Sugumar, my colleague, who will cover an overview of the Qualified Clinical Data Registry measures, as well as review the differences in QCDR quality measures and MIPS quality measures. Sophia, you have the floor.
Thanks, Susan. Hi, everyone. My name is Sophia Sugumar, and as Susan mentioned, I do work with her on the MIPS quality team. I do lead the QCDR registry work with Dr. Daniel Green, who's our medical officer and the lead for the quality performance category. So we wanted to spend a few slides going through our QCDR measures and how they differ from the MIPS quality measures. Okay. So QCDR measures are measures that are developed by qualified clinical data registries that are typically known as third-party intermediaries that self-nominate or submit an application to us during an application period. And they are required to meet certain criteria, such as having measure development expertise and having some clinical expertise. And they can develop their own measures. They can develop up to 30 measures. So we offer QCDR applicants an opportunity, and this is demonstrated through this timeline here, of meeting with us prior to self-nomination to do what we call preview calls, where we meet with QCDRs one-on-one to kind of go through their measure concepts that they're looking to implement prior to self-nomination. This will give them an idea of our preliminary feedback. We usually encourage QCDR applicants to do an environmental scan to see what measures are out there currently within our MIPS quality measure inventory, but also looking at our existing QCDR measure inventory in order to avoid duplication, but also to ensure that QCDRs are aware of the standards to which we are trying to hold their measures to. So we are trying to move away from process measures in a sense and also have more robust measures in our program. So the first initial part of the year, we do spend offering QCDR measure preview calls, which are those one-on-one calls. And at that point, they will, QCDRs typically will take the feedback we provide, the initial feedback we provide, and make adjustments to any QCDR measures that they are attempting to self-nominate. And then they will self-nominate with their application, their measures that they wish for us to consider. The self-nomination period typically opens on July 1st, and it will close this year on September 3rd, I believe at 8 p.m. Eastern Time. And there is detailed information on the self-nomination application cycle and the detailed process related information on our QPP resource library, if that's helpful for you. We have a toolkit available that's known as the QCDR and Qualified Registry Self-Nomination Toolkit that provides detailed information there. So as a part of the self-nomination application, QCDRs can self-nominate up to 30 QCDR measures for our consideration. So we provide a QCDR measure template in which QCDRs complete and provide all required fields regarding their measure specification, and we do take some time to review that. As a part of our review process, we will possibly come to QCDRs in between asking for clarifications or requesting revisions. And so there is a part of the process where we provide feedback or request revisions or provide some notification as to what we're deciding with their measures. If we decide to approve a QCDR measure or provisionally approve a QCDR measure, we will work to finalize the QCDR measure specification. And then we will also share that finalized QCDR measure specification with our product team for programming purposes. As a part of the submission period, which typically opens January 1, the January 1st after the performance period, so for 2019, submission should open January 1 of 2020 and go till end of March, I believe. That would be the point in time in which QCDRs who have providers that are interested in submitting data on those QCDR measures would submit data on those measures at that point to CMS to meet the MIPS quality reporting requirements. And if a QCDR chooses to or wishes to continue the use of their measure that's been previously approved, they will have to self-nominate that measure again next year. Self-nomination occurs on an annual basis, and so as a QCDR self-nominates, they need to resubmit the previously approved measure, or they can submit new measures for our consideration. And it's at that point, if the QCDR decides to make any changes to their measures, that would be the point where we would look to review those changes and possibly accept or request any additional feedback on those changes. As I mentioned before, with the QCDR measures, the time to submit those is during our self-nomination period. And I did say you could submit as a QCDR up to 30 measures for our consideration, and that's speaking solely of QCDR measures. QCDRs can also support the MIPS quality measure reporting, and that does not count towards the count of 30. So the reporting of QCDR measures is used to meet the MIPS performance category, and we will provide feedback and notify the QCDRs if your measures are approved or provisionally approved or rejected within the weeks after closing of the self-nomination period and prior to the opening of the performance period, for example, prior to January 1 of 2020. QCDR measures are clinical quality measures which are developed and maintained by QCDRs. They do not go through the 20-month cycle that the MIPS quality measures go through, and I think we're going to discuss that a little bit more in another slide. QCDR measures should be clinically relevant and evidence-based, and they should be based off of current clinical guidelines and should be indicative and should provide evidence that there is a performance gap and there's variation. Having topped-out measures in our program is something we tend to move away from. It's counterintuitive to the Meaningful Measure Initiative, so that is one thing we encourage all our QCDRs to continuously be cognizant of, is that ensuring that they submit measures where there is an evidence-based gap, or that they are monitoring performance on their measures to ensure that there is continuing variation. QCDR measures should be analytically sound and fully developed. We will not accept measures concepts that are just simply in the concept phase. We, at this point, do not currently require that QCDR measures, complete reliability and validity testing. So that's one area where we're different from the MIPS quality measures. But they must QCDRs must provide performance data if possible, which will help us demonstrate, one, that the measure is you're able to collect on the measure, but then also that there's actual performance gap on the measure. QCDR measures will not be accepted if they are duplicative of MIPS quality measures, whether that be MIPS quality measures we currently have in the program or ones that we've retired. And we typically say that they should not be duplicative of previously retired PQRS measures as well. Okay, here's that compare and contrast between the MIPS quality measures and the QCDR measures. As you can see by the first item on the table, we have a large volume of QCDR measures in our program. For MIPS quality, we have about 257, and for QCDR measures, about 752. We have about 127 QCDRs currently in the program. So the MIPS quality measures, as Susan went over, have to go through the annual call for measures process and also have to be proposed and finalized through notice and comment rulemaking. With the QCDRs, it's different. It's a separate process that occurs, they have to submit their measures and application during the self-nomination period, which again opens July 1st and then closes September 3rd. For the MIPS quality measures, you can submit an unlimited number of measures where the QCDRs are limited to up to 30. We do not have, for the QCDR measures, MACRA map review. We don't go to the NQF with our QCDR measures, so that's where we differ with the MIPS quality measures. We do require MIPS QCDR measures to be fully developed, as I previously mentioned, and there would be performance gap information available. However, the MIPS quality measures requirement is far more robust in that you are required to complete testing and ensure the measure is reliable, valid, and implementable. And the last item is that we do not propose and finalize QCDR measures through rulemaking. They are done through a sub-regulatory process, and that's how they differ. So typically, the self-nom period closes September 3rd for this year, and so from September 3rd up until probably the November, December timeframe is when we work to finalize what measures we will approve or provisionally approve for the upcoming performance period, and there will be communications in that time frame with the QCDR applicant as to whether or not they've been approved as a QCDR, and also whether or not their measures will be moving forward for the 2020 performance period. After that, we do tend to finalize a list of approved vendors for public posting, and we also list what QCDR measures or MIPS quality measures they will report on, and possibly any other services they will provide in addition to what fees they charge for their providers to use their QCDR. All right. To go through some of the QCDR measure challenges or limitations we have come across, one of them has been with the volume of QCDRs volume of entities wishing to become a QCDR and the number of QCDRs who've developed and submitted QCDR measure concepts, we've of course come across instances where there has been duplication in measure concepts. Now, in an effort to reduce the number of duplicative measures in the program, but also ensure that we don't accept duplicative measures in general because it is counterintuitive, as I said before, to the Meaningful Measure initiative of the administrators, we do tend to request, as a part of our analysis and review of all submitted QCDR measures, we tend to either request that you harmonize with another QCDR to submit in a future year one comprehensive QCDR measure that covers the entire concept, or we will ask that you use another QCDR's measure. The reason why we do that is because of having multiple measures that cover the same concept means that there's a likelihood of a measure being adopted at a lower rate and thereby not able to meet our benchmarking threshold and case minimum threshold. So I think it's that threshold we set is that measures have to be reported by 20 providers with 20 cases each, 20 providers or groups with 20 cases each, and we've come to find that when measures are duplicative, that we get measures that have very low reporting volumes where they cannot be benchmarked, and so that then defaults to a clinician getting only 3 points for a measure. So in an effort to encourage robust benchmarking, we have also encouraged QCDRs to harmonize their measures when possible to to collect more data on the measures, thereby allowing for benchmarking capabilities. One other change, an item we noticed that we are looking to change with even the 2020 self-nomination period is measure specifications for QCDR measures did not include the detailed coding that other QCDRs might find helpful when looking to borrow a QCDR measure from another QCDR. So how we've changed this is we've actually updated our QCDR measure template to include a field for QCDRs to indicate what applicable settings and coding that goes with that. So that way, those that are interested in using the measure can see whether that they can really use the measure or not. Some of the benefits with regards to QCDR measures is because we don't go through notice and comment rulemaking, and because they're not tested, we do hold QCDRs to expect them to be more nimble. That means if we have requests for revisions as we review the measures, we expect that they would be able to make those, if they're minor, within a shorter time period. We expect that they would be able to ensure that their measures reflect the most current clinical guideline prior to submitting it to the self-nomination period. We also offer the preview calls. The QCDR measure preview calls we've come to find that have been very helpful for our QCDRs. They've provided us with some positive feedback. They appreciate the preliminary feedback we provide. We tend to try to be as honest as we can, whether we think this is a good measure idea or whether we believe it's similar to something we already have in our program. So it just offers the QCDR an opportunity to get our preliminary feedback. That way they can decide whether or not that's a measure they would like to move forward with or whether they would like to go a different way. The other positive benefit of it is that the timeline to get a measure into our program is much shorter. It's not necessarily the 20-month process that MIPS quality measures have to go through. If you self-nominate by September 3rd, you find out prior to the end of the year whether your measure and you as a QCDR are approved for the upcoming performance period. So it's definitely a much more accelerated way to get measures into the program. For that reason, we do have expectations from the CMS perspective that QCDR should be able to develop innovative measures that perhaps cover gaps that are found within our MIPS quality measure set. We typically have a lot of specialty societies or healthcare systems that develop measures specifically for their specialists or subspecialists, which we feel address those gaps. And so we find that that's the expectation we'd like to hold our QCDRs to. So with regards to our QCDR measure decisions, we do have we have measures that are approved, but then we also have measures that are provisionally approved, which just gives our QCDRs an indicator. It's more of an internal status update between the CMS and our QCDRs. If we provisionally approve your measure, we're letting you know that your measure is approved for this year, but we are looking for you to provide additional performance period data or complete a requested action like combining your measures or harmonizing with another QCDR in order for your measure to be considered in the future. So that provisional approval is really to give those QCDRs a heads up and an understanding that your approval is basically temporary until you've made the necessary updates or completed the requested action as we've requested through the self-nomination period. Okay, with that, I'm going to turn the call over to Dan Reiner, our physician compare lead.
Thank you so much, Sophia. So I'm just going to talk for a couple of minutes here about how some of these measures make their way onto Physician Compare. So we can go to the next slide, please. So it looks like a little outdated on this top bullet. So the 2017 QPP data, we did preview that in late 2018. And due to some stakeholder feedback and being the first year transferring from PQRS to QPP, we did another preview in early 2019. And those data did go live on Physician Compare in mid-July, so a few weeks ago. The things that did go live in July were MIPS and QCDR measures, the CAPS surveys, ACI measures, advancing care information, and also final and category scores. So on Physician Compare, we publicly report measures in two different ways. So first, the downloadable database, which is very much what it sounds like. It's a database with a bunch of measure information that you can download. This is geared a little more for researchers, data analysts, clinicians, but beneficiaries and caregivers are also welcome to use it, and they do from time to time. And then we also have the live site with profile pages where we also publicly report information, and that is very specifically geared to caregivers and beneficiaries for them to use to help choose a clinician. So for measures to qualify to be publicly reported, they have to go through a couple of steps. First, they need to go through our kind of statistical analysis process. They need to be valid, reliable, accurate, comparable across submission types. And if the measures meet those criteria, then they are eligible to go in the downloadable database. To get on the profile pages, we then have to go one step further where we do consumer testing with beneficiaries and caregivers to see if the measures resonate with them, to find out if it's something they actually want to see, if it's something they actually find helpful in choosing a clinician, to see if it's something that they understand. The 2019, jump straight to 2019, the 2019 QPP data we would expect to be available for public reporting in late 2020, and the 2018 data, which we are currently working with, we would expect that to be available for publicly reporting late this year or early next year. And if you do want any additional information on Physician Compare, we do have what's called the Physician Compare Initiative page, where you can find all sorts of documents and explainers and tons of information. And if I didn't mention it before, the downloadable database, you can find that at data.medicare.gov. And I will throw it back now to Brina Ravel.
Thanks, Dan. All right, at this time, we're going to unmute the phone lines for questions. Please remember to mute yourself if you're not talking to help us keep background noise to a minimum. If we get too much background noise when we unmute the lines, we will have to remute folks and then just limit questions to the WebEx chat and Q&A features. And as a reminder, you can also use the hand raise feature and we can call on you to ask your question. We did already receive a couple of questions via Q&A, but I'll pause for a moment in case anyone on the phone would like to voice a question now. Okay. Martin, if you want to just go ahead and remute, we'll go with the questions we got via the chat feature. So this first question is, when will the PI hardship exception application be released?
Brent, I don't think we have a PI SME on the call to answer that question. That might be one we can possibly circle back on.
Great, thanks. We will follow up via email then, the person who asked that call. Another question, is there an effort to include more outcome measures in MIPS so that the portfolio isn't so leaned toward process measures?
This is Sophia. Yes, in general, I think we've signaled through our rules over the past 2 to 3 years, that we are trying to move away from process measures and have more robust outcome-based measures or patient-reported outcome measures in our program. So certainly, I believe through our pre-rulemaking website and our call for measures, I think we try to emphasize that. And also from the QCDR side, with the QCDR measures, we tend to emphasize the want for more outcome-based measures in our program.
Mm-hmm. We're also very keen on getting patient-reported outcome measures. So.
Thanks, both. This question is probably also for Sophia. If not reviewed by the MAP, who reviews QCDR measures when they're submitted?
We have several rounds of CMS review as well as our contractor review. So typically the measures are extracted by our contractors, but then reviewed with the quality lead, and sometimes we include senior levels of senior levels of CMS leadership, but then also we have a group of CMS medical officers as well who help with the review process when needed.
Thank you. Okay, it looks like we have one more question. Again, probably also for Sophia. Why don't the QCDR measures require the same level of testing as MIPS measures?
That's a good question. Actually, that is something that hasn't been around since the QCDRs have been around since the days of PKRS, and it wasn't a requirement back then. But as we move towards the MIPS program, that is something we have sought comment on in previous rulemaking cycles as to whether we would like to ideally raise the bar on QCDR measures to make them equivalent to MIPS quality measures in a sense that we can, have this reliable testing done. So that is something we are looking at, and I would encourage the questioner to read the 2020 rule that just came out, the NPRM, as we address testing there.
Great. Thank you so much, Sophia, and also to Susan and Dan for presenting today. We don't have any more questions, so we can go ahead and wrap up. Our next info session is going to actually be in October, so we'll be sending out an announcement via the MACRA listserv later this month with information about that. And in the meantime, enjoy your summers, and thank you all for participating. Have a good day.